Dear colleague and friends, good afternoon, good morning, and welcome. I'm really glad that the WEMS Hippocrates webinar have restarted. As we will see, we have changed the scheduling to simplify the organization of webinar, meaning that there will be no longer be 3 lectures on 3 successive days, but one at a time. And I'm sure that this simpler organization will result in more webinars being held. And now I will leave the floor to Professor Neo, Chairman of Hippocrates Foundation, for a welcome, and then to Professor Sogstad, Chief of Web Scientific Board. He will have the pleasure of introducing Professor Samir Gupta, and I think I thank Professor Gupta for his valuable cooperation. And please join.
Yeah, it's a real honor to have you involved with this conference, Dr. Gupta. This is an area that is such an important one and has evolved so rapidly over the last 2 decades. I still remember the earlier days of neonatology when we were just simply taking our best guess on how to treat some of these babies from a hemodynamic pharmacologic perspective. And now with your work and that of several colleagues, we are beginning to be able to put some science and some real knowledge behind some of our decisions, and I'm just thrilled to be able to have you provide this lecture. So I'm going to give it over to Ola right now to make a further introduction.
Thank you very much, Joe. It's also a pleasure and honor to welcome each and every one of you to this new webinar about drug management and echocardiography. There are more than 1,000 registered for this webinar. I think it's fabulous from all over the world. So heartily welcome all of you. And then it's an honor for me to introduce the speaker of today, my good friend Samir Gupta. Samir is division chief of neonatology at the big Children's Hospital Sidra in Qatar, and he's professor of neonatology at the Durham University, UK, and has been chief investigator of several studies, such as the Baby Oscar trial, and is also a steering committee member of the special interest group of ESPR on echocardiography. He's also member of various international and neonatal hemodynamics advisory committees, and since 2010, he has been the conference director for the annual International Neonatal Hemodynamics and Cardiology Conference in UK. So, Samir, we are really looking forward for your lecture today, drug management and echocardiography. Please, the microphone is yours.
Thank you very much, Professor Sogstad, for your kind introduction. And I also would like to thank Professor Corrado Moratti and Professor Joseph New, the UNPS and the Hippocrates collaboration for giving me this opportunity to share the views and the integration of echocardiography in day-to-day care when guiding the drug management of the complex and sick babies. Katrina, can I have my slides, please?
Before you continue, I just want to remind the audience that you are free to send in questions in the question answer box, the QA box at the bottom of the screen.
Can you see my slides?
No, Professor.
So I'll just go back to Zoom and try and share the slide again. 1 second. Okay.
Now, yes, thank you.
Okay. Well, thank you again. And I have no disclosures to state. Recently, the guidelines and recommendations for targeted neonatal echocardiography and the point-of-care ultrasound for in the neonatal intensive care units has been published in association with the American Society of Echocardiography. This is a revision of the previous guidelines published in 2011 and lays the foundation for increasing the integration of the bedside echocardiography for day-to-day management of sick babies on the intensive care. Before we move on to the individual indications, I think it is important to recognize the transition on the lung, where the canalicular stages, it moves gradually into the postnatal well-developed alveolar stage. And similarly, as you can see, the pulmonary vascular resistance, it increases just before the delivery, and soon after the delivery, it drops significantly, which is the transition. The systemic vascular resistance gradually increases, and postnatally it continues to increase, creating a pressure gradient between the systemic and the pulmonary circulation, which is very important to transition from parallel to series circulation as it is in the adult life. Now, based on this transition, one can find the different types of cardiovascular adaptation, and this can vary from a normal, which is in green, without subsequent pulmonary hypertension. So it's a smooth transition. The one in brown is a normal initial drop with subsequent increase in the pressures, and that is essentially in 10% of the babies where they develop a late pulmonary hypertension. The one which is in yellow is a delayed adaptation without subsequent pulmonary hypertension, and these are the babies who might require some support for some period of time. The one in the black is a delayed adaptation with subsequent pulmonary hypertension. Again, in about a third of the babies, one can see this. And the fourth is a persistent pulmonary hypertension, where there is an increase from the start, and it continues to stay up, and it is seen about 17%. So you would see that a normal transition is only seen in a third, and in the remaining, there could be one of the four other variants of transition. This is very important when we manage our babies and try and see that at what point of time, which drug therapy is important. So the application of neonatologist echocardiography has been published in a series from our group in pediatric research on individual components of the disease states. And one would recognize that the echocardiographic features of persistent pulmonary hypertension as a first problem, if we take on a day-to-day basis, is essentially due to the high pulmonary pressures, which lead to right to left shunting across the PDA, the regurgitant jet from right ventricle to right atrium, that's a tricuspid regurgitation, right to left flow across the interatrial septum, and then all these assessments are quite important when we find out the severity of pulmonary hypertension and the kind of drug therapy that we want to use. The publication that we have made is essentially to look at the various modalities to assess the pulmonary artery pressure, the pulmonary vascular resistance, the RV performance, and the shunts using the bedside echocardiography. This is a separate talk in itself, and I don't think we have time to delve deeper into the individual components, but the reference is available for those who are interested in looking at it. Now, this is quite an important schema or cartoon by Dr. Satyan, where I would like you to concentrate on the black bar and the blue bar. The black bar is the ductal shunt, and the blue bar is the atrial shunt. Depending upon the shunt, as you see in the blue bar, which is the atrial shunt, if it is right to left, is above the horizontal line, and left to right is below the horizontal line. Same way, the ductal shunt is left to right on the left of your screen, and right to left on the right of the screen. Based on this, you would see the first one, where it is on the left, on the top, is a duct-dependent pulmonary circulation, such as in conditions like tricuspid atresia or other CCHDs, where the initial treatment required is a prostaglandin E. In these situations, you could find the left to right flow across the ductus and the right to left flow across the atria. So this is the duct dependent CCHD requiring the treatment with prostaglandin depending upon the necessity soon after birth or after the pediatric cardiology evaluation. The second on the right is a persistent pulmonary hypertension of the newborn, where the shunt, as you can see, is right to left across the atria and right to left across the PDA. These are the babies with pulmonary hypertension, but these are pre-capillary pulmonary hypertension, and they essentially require lung recruitment and pulmonary vasodilators. The third one is the pulmonary venous hypertension, and this is essentially very different from the one which is pre-capillary. So one on the lower right, essentially it is due to the left ventricular dysfunction, and this leads to the back pressure where the left atrium gets dilated and the blood flows from left atrium to the right atrium. But you would note that across the PDA, the shunting is right to left. This is very important to recognize because these are the cases of post-capillary pulmonary hypertension called as pulmonary venous hypertension. In these cases, pulmonary vasodilators can make the situation worse, and the ideal drug of choice in these cases is either milrinone or prostaglandin E1 as the case may be. The fourth on the lower left is a normal with where there are the shunts are normal left to right across atria and left to right across the PDA. And these are the babies where the parenchymal disease is the primary cause, and what you would require is a diagnosis of lung disease and try to manage the respiratory system with the lung recruitment, surfactant, and modulating the peak and expiratory pressures. So you can see that how the echocardiography can be used on the bedside to evaluate the neonatal hypoxemia, giving the 4 different phenotypes, which is essentially a duct-dependent CCHD, or pulmonary hypertension pre-capillary, or a post-capillary, or a lung disease without pulmonary hypertension. Now, if you find a cardiac dysfunction in pulmonary hypertension, it is important to recognize because these babies can essentially also present with shock, and we'll talk more about it. So if the pulmonary vascular resistance is increased, it can lead to RV systolic and diastolic dysfunction, decreases the right ventricular output, and decreases the pulmonary blood flow. This essentially will lead to decreased preload of the left ventricle, decreased left ventricular function, and decreased left ventricular output. And hence, with the decreased preload, there would be systemic hypoperfusion, and these babies could present with shock. So, what are the different types of shock in pulmonary hypertension? It could be hypovolemic due to acute blood loss or fluid electrolyte loss. It could be vasoplegic due to sepsis or endothelial injury. It could be cardiogenic due to myocardial ischemia, arrhythmia, or heart failure, and obstructive in conditions like tension pneumothorax and cardiac tamponade. So one size does not fit all, and one needs to identify what is causing the underlying problem. And I think here it is important to assess the treatment of a cardiac dysfunction because it varies whether it is a right-sided or a left-sided dysfunction. Here what you are seeing in yellow is a right ventricular dysfunction with impaired oxygenation. This can be assessed by the echocardiography on the bedside, and in these cases, the first line therapy is a pulmonary vasodilator such as inhaled nitric oxide. In babies who do not respond, there is a systematic escalation of treatment by addition of IV sildenafil or for right ventricular dysfunction, milrinone. The third line, if the duct is closing, then one might want to open up the duct by giving prostacyclin, or some of these babies with a significant dysfunction are candidates for extracorporeal membrane oxygenation. And I think this is important because one, to consider the prostaglandin E1 infusion to keep the duct open, and that allows the right ventricular to unload. However, in another phenotype, where there is a left ventricular dysfunction or a low blood pressure, the first line cardiotrope is milrinone or dobutamine or a low dose epinephrine as the practice on your own unit. The second line cardiotrope could be a low dose epinephrine or hydrocortisone in certain situations. But these babies should be very closely monitored because these might require very early a VA ECMO as the left ventricle is dysfunctional. Moving on to congenital diaphragmatic hernia, it is important to recognize that there is a interaction of the right ventricle and the left ventricle, and one has to look into this because unlike the old concept of managing diaphragmatic hernias as a singular phenomena, now various phenotypes of CDH are recognized. Broadly, they can be divided into a right heart phenotype and a left heart phenotype, and the differences are primarily because in the right heart phenotype, the systemic blood flow is dependent upon the duct where the blood is flowing from the right to left due to RV dysfunction, and hence unloading the right ventricle before it fails due to increased downstream pressures in the lungs. And this is mainly because of the primary RV dysfunction. The left heart phenotype commonly happens in the left-sided CDH, where there is a pressure on the left ventricle, decreasing the capacity and end-diastolic volume of the left ventricle. And here, the systemic flow is primarily maintained through the ductors, again with the right to left flow. So the different phenotypes allow us in identifying where to target the therapy and which drug to use. Now, one thing need to be recognized here, that if we are managing babies, one needs to find out that is the cardiac function normal. Normally, the right-sided pressures using echocardiography are assessed using tricuspid regurgitant jet, because using the Bernoulli's equation, the 4 times the peak velocity square plus right atrial pressure gives the right-sided pressure. However, if the right ventricular function is abnormal or decreased, then the TR jet is not normal and it will underestimate the right-sided pressures. So one needs to be cognizant about this, that their RV function is normal before commenting about the right-sided pressures using echocardiography. It is also important that the shunt across the PDA is normally bidirectional. And if you ever find that the shunt across the PDA is 100% right to left, one needs to think outside the box and take an early steps to rule out a congenital heart disease which is duct dependent, such as TAPVD, or it could be pulmonary atresia with intact septum, etc. We also come across the INO refractory pulmonary hypertension, and I think these are the situations where it is increased pulmonary vascular resistance. There is leading to the requirement for a PVR manipulation such as milrinone and sildenafil as vasodilators. There could be the right ventricular dysfunction where we need to increase the preload, give inotropes such as milrinone or prostaglandin as I already mentioned, and PDA flow manipulation, and at times very early in the disease, many units they practice by giving the low dose vasopressin or norepinephrine, increasing the SVR to reverse the shunt. But this should not be the default practice because we are not treating the underlying pathology here. So this is just a schema with the acute pulmonary hypertension where the INO has to be used. One can utilize the functional echo where it is INO resistant. And why it is INO resistant, one can look at the right ventricular function. If it is dysfunctional, one can look what are the oxygen requirements. If the oxygen requirement is less than 60%, we can still watch and see whether the transition happens where the sensitivity increases to nitric. But if the oxygen requirement is more than 60%, then it is adjuvant use of milrinone or sildenafil, and then repeat the functional echo to decide whether there is an optimization of lung recruitment required, or milrinone has to be further titrated, or if initiating other treatments are important, such as if the therapeutic hypothermia was given, then to reduce then to increase the temperature. Now, if the RV dysfunction is present alongside, then one needs to see whether it is also causing hypotension. If it is not causing hypotension, then milrinone is easy to use because one of the side effects of milrinone is reduction in the systemic vascular resistance, and or dobutamine or low-dose epinephrine. But if the hypotension is present and the oxygen requirements are low, one can use plain vasopressin because the SVR increasing drug, or norepinephrine. But if the FiO2 is more than 60%, then one can go in on the same line but monitor more closely with the echocardiography. Now, these are just some examples. Here one can always see, and those who are proficient in echo might be recognizing here, that it's a low pulmonary vein flow, as you can see here. Okay, the right ventricular ejection time to the pulmonary artery acceleration time is abnormal here. The ejection fraction is 65%, and the right ventricular TAPC, which is the tricuspid annular plane excursion, is very much reduced. And then it is here the systolic eccentricity index, which is more or less the compression of the left ventricle due to the right ventricle, is 1.6, which is high. So in this case, the diagnosis is suprasystemic pulmonary hypertension, decreased RV systolic performance, and high pulmonary vascular index with a flat intravascular septum. So in this situation, one would treat with a pulmonary vasodilatation and appropriately titrate the inotropes, that is using nitric oxide, and add milrinone. Take this another example, which is a 25-week baby, which is a rupture membranes of 8 weeks, oxygen requirement of 40%, blood pressure is only 25/11, left ventricular output is normal, 150 to about 300 mils per kg per minute is normal. Right ventricular output is also looking normal, 216 mils per kg per minute, and the RV-ET2 pad is 3.5, which is essentially normal. Ejection fraction looks normal. TAPC is about normal because it's 25-weeker, so 5.7 is normal. And systolic eccentricity index is 0.96, which is again normal. So here is a situation which is a normal biventricular subfunction with normal cardiac output, no evidence of pulmonary hypertension, normal pulmonary vascular resistance, bidirectional PDA due to severity of low SVR, and the treatment here is plain vasopressor with or without volume and no other treatment required. So this is a benefit of echo in deciding whether the baby needs a treatment or not. Now, just a word, I've been talking about the use of ductus arteriosus and keep it open to unload the right ventricle or the left ventricle. So one could see when the ductus arteriosus is and why it is important in the RV function. Now look at a situation where there is a hypoxic respiratory failure with a low cardiac output. This PDA can be closed or restricted. If it is not closed or restrictive and there is RV dysfunction, one can start the nitric oxide. But if it is the RV dysfunction is present, then, as I said before, is the patient hypotensive or not, and accordingly decide vasopressin. However, if the LV dysfunction is present, then nitric oxide should be stopped, and if it is not present, then one could wean the oxygen and start positive inotropes and reevaluate. These schemas are just a guide and help you utilizing and integrating the functional echo in your drug management on a day-to-day basis. Now, this is a slightly different scenario where a duct which is staying open for a long period of time, say it was open for 2 weeks or 3 weeks or even longer. Some of these babies, they develop pulmonary hypertension over a period of time. This pulmonary hypertension, which is flow related, is different from the pulmonary hypertension, which is due to the pulmonary vascular remodeling due to primary lung disease, such as meconium aspiration syndrome, infection, or congenital diaphragmatic hernia or other conditions. And the management of this is slightly different. In these situations, the duct is very, very large and the pulmonary hypertension is present. These ducts should not be closed when the right to left shunting is secondary to suprasystemic pulmonary artery pressure. Because in these situations, the PDA is working as a pop-off valve for the cardiac output. So one should try decreasing the PVR and with the pulmonary vasodilator and see if there is a worsening of the shunting or not. If there is a worsening of shunting and the baby is not responding, then these babies should not be closed. Now, do mind you, this image is not representative. It should be a right to left flow, but by mistake, it is the different, the cartoon here. If the PVR shows reactivity and decreases after the treatment, this may potentially allow the PDA closure in future. It has also been tried to put a fenestrated device in the duct to allow a gradual reduction in the flow, and hence one needs to be careful about closing the duct with a right to left flow in babies with pulmonary hypertension and a large PDA. So we have talked about the pulmonary hypertension, various phenotypes and the conditions associated, and how the drug management could be done utilizing the functional echo on the bedside. Now let's move on to the management of the neonatal shock. And again, this is a publication from the group where you can find more details of how to perform this. Now here is the right and the left ventricle, and there is a difference in the geometry and the arrangement of the fibers in the right ventricle and the left ventricle. The left ventricle is having the longitudinal, circumferential, and the radial muscle fibers, whereas the right ventricle has predominantly the longitudinal muscle fibers. So the echocardiographic measurements of the cardiac function, just to name, can be divided into various categories. One is a blood flow measurement, which is an indirect measure, and it looks at the cardiac output. And the cavity measurement can be done using the fractional shortening and the ejection fraction. There are various time indices which can be used, and that is systolic to diastolic ratio, very less frequently used. The diastolic function can be assessed using the myocardial performance index or the TI index. We can look at the pulmonary artery acceleration time and the right ventricle ejection time. Essentially, it is giving you that how quickly the ventricle is ejecting and what the downstream pressures are. And the TDI can be used for isovolumetric contraction time and isovolumetric relaxation time. Other indices for the diastolic function are the E, that is the flow across the wall in the diastole, which is early, and then using the E prime, which is mainly the myocardial contraction in the early time. So this has been used for assessing the diastolic function. Then there are various global longitudinal wall measurements and the AV plane velocity and strain rates, which are the advanced measures. And regional wall measurements can also be done using the longitudinal and the circumferential and the radial strain. I'm just going to touch so that you are aware of it, but not go deeper into this. Now, this is a pulse wave and the color wave tissue Doppler imaging, where you can see the spectrum of velocities sampled between the calipers, as you can between here. And on the right side is the average of velocities from the sample area, which is the color tissue Doppler. So essentially, the tissue Doppler imaging enables the post-processing and utilizing the indices. It is more precise because it is not looking at the primarily flow, but it is looking at the myocardial contractility and relaxation. So this is a low velocity, very opposite to the Doppler that you see, and it gives you a myocardial function, and one can read a bit in detail how it can be integrated in your day-to-day measurements. This is a typical strain where the 2D speckle tracking is done, and the advantage is that the color flow map, it gives you a segmental contraction of the ventricle. Initially, it came for the left ventricle, but now it is available for the right ventricle as well as the left atrium. So the advantage of this is you can identify any segmental dysfunction of the ventricle walls which are affected, and these are seen after segmental ischemia, hypoxic encephalopathy, the coronary artery syndromes, and so forth. So the question comes is, how do you select the inotropes in infants with impaired perfusion or shock? So again, as we know that the shock can be divided into hypovolemic shock, the cardiogenic shock, the distributive shock, and the obstructive shock, and various causes for them are labeled here. One need to also know that the drug that you are using, what is the effect of the drug? So essentially, one can classify the effect of the drug into 5 different categories. Whether drug is causing the vasoconstriction, so these are the drugs. Whether it is curing pure inotropy, so these are the drugs. Pure vasodilatation, inotropy and vasoconstriction, inotropy and vasodilatation. So why these have been grouped by Wilhelm in his publication is mainly because when you select a drug, if you know what it is going to cause, then you can titrate it, or you can select it for the purpose that you want to start it. And this is a slide which is, I'll just spend about a few seconds. There are various drugs and the effects can be dose dependent. So for example, if you take dobutamine, at 20 mics, it is causing a significant vasodilatation and the contractility, which is on the y-axis, and on the x-axis, you are seeing on the right vasoconstriction, on the left vasodilatation. So here on the left vasodilatation and the contractility, you can see if the dobutamine started 5 mics, yes, there is a contractility, but there might not be any effect on vasodilatation. But as you increase the dose to 20, there is a significant vasodilatation. Vasopressin is a drug which does not have any effect on contractility, and is a significant vasoconstrictor. Norepinephrine has some effect on the contractility and again a vasoconstrictor. Same way it is looking at milrinone, which is about here. It is a vasodilator drug with a good contractility, so it's called a lucitrope. And the dopamine, which is less so frequently used, has a primarily vasoconstrictive effect, and it also increases the contractility. Epinephrine, low doses, it causes vasodilatation and some contraction, but at a high doses, it causes vasoconstriction. So the use in the neonates, particularly in the extreme preterm babies, one tends to use a lower dose of the epinephrine so that it allows the contraction as well as improves the systemic flow. So this is something important so that you are aware of the drug doses and their effects which are utilized in managing the conditions. So it's a precision medicine, and hence one needs to be, as I said, what is the diagnosis, what is the hemodynamic problem, which inotrope you want to use, and why you want to use the inotrope, and when do you want to stop it, and what is going to constitute your success criteria. What I mean to say is, starting a drug and leaving it on is not an option. And we need to avoid the multiple use of inotrope, what I call inotrope soup, because that is not the right thing. Now, looking at the echocardiography, one can find out whether there is a low cardiac output, and then there are various causes of low cardiac output, whether it's a low flow, impaired filling, is it a rhythm problem or a myocardial injury, failed adaptation, or a vasoconstriction. Based on that, it could be reduced preload, reduced contractility, or increased afterload. All of them can give rise to low cardiac output, but if it's a reduced contractility, you want to use an inotrope. If it's an increased afterload, you want to use a drug which reduces the afterload like milrinone as well as improve the contraction. But if there's a reduced preload, then do not use inotrope because it will cause tachycardia. And instead, you want to use the volume expanders which can stay in the circulation. So approach to systolic hypotension in a you need to manage the non-cardiovascular factors for the low filling. That includes the ventilation also, treatment of pneumothorax. You need to justify the hypovolemia and administration of the fluid boluses. Consider dobutamine initially, and if required, epinephrine, and wean quickly if it is not required. With associated hypoxemia, consider pulmonary hypertension and try to reduce the PVR. Milrinone, vasopressin, as I described, to be used in specific situations as your echocardiography findings. If the hypotension or shock is driven due to the right ventricular dysfunction, a low right ventricular output, as I said in the or mentioned in the earlier slide, there's a significant RV-LV interaction. It needs to be considered that the inotrope are the first line, and it also responds to pulmonary vasodilatation if it is coexistent pulmonary hypertension. If there's a right ventricular diastolic dysfunction that needs attention, then the failing RV is very sensitive to fluid, and one needs to be very careful in giving more fluid. Milrinone is likely to be effective in these cases because, say, lucitrope allows the relaxation of the heart and improves the contraction. But monitor the RV at systemic pressures because, as I said before, opening the duct can improve your cardiac output. Now, coming to the factors contributing to low vascular resistance, that is decreased systemic vascular resistance, that is going to cause a diastolic hypotension. It can be due to vasodilation, like various conditions, enlarged vascular bed, or hypovolemia. All of them, they cause low vascular resistance. In these situations, liberal volume replacement when volume loss is there is key to success. And this is very commonly seen in abdominal wall defects and blood loss. If there's acute hemorrhage, rightly so, we give packed cell transfusion. Try to avoid inotropes because they can cause tachycardia in a hypercontractile state. Vasopressin is a drug to be chosen. If it's a hemodynamic significant PDA, use other measures such as minimize oxygen permissive hypercapnia, etc. And low dose, and if the cardiac output is low, then consider dobutamine and avoid systemic vasopressors. If it is an infective pathology, volume replacement and the drugs like epinephrine, vasopressin, some units still use dopamine. They are very helpful, and early use of hydrocortisone is also indicated. The most difficult situation that we all face in a day-to-day bedside care is a combined systolic and diastolic hypotension. This is a situation where the inotrope soup is very frequent. I think this is one single indication. Even if you do not have someone to do an echo on your bedside, try to get a cardiologist or help or transfer to appropriate center so that babies can be managed appropriately. They do require a functional echocardiography. The hypotension can be profound, and if you are in doubt and you do not know what to do, manage them as a warm shock with volume and drugs to increase the SVR. When associated left ventricular dysfunction is there, epinephrine need to be started early, and hydrocortisone is another drug that needs to be thrown in early, because if the steroids are low, then there is an end organ poor responsiveness to the inherent or the inotropes which are in the body. Now look at these four different things or cases. Case 1 is 7-hour-old child with a normal blood pressure but low systemic blood flow. Case 2 is a baby which is 20-minute-old, low blood pressure and hypovolemic. Case 3 is a 10-hour-old baby with low blood pressure and a large PDA. And case 4 is a 32-hour-old baby which is low blood pressure but normal systemic flow. Now, you are not going to treat all the four of them with the same line, and I would urge that what I just presented with the approaching the systolic, diastolic, or systolic and diastolic hypertension, choose the drugs wisely and use to treat the baby based on the echocardiographic findings. So the key points for managing the shock are low flow and hypotension associated with the worst outcome. The different inotropes have different effects on flow and blood pressure. Non-responders have a worse outcome. Identify the cause and select the inotrope based on what you want to achieve. Systemic approach is the way forward. And the functional echocardiography use cannot be underestimated in these conditions, such as non-response to inotrope or vasopressor, unusual presentation when you don't know what you are treating, associated with hypoxia or pulmonary hypertension because I have presented various phenotypes and the treatment is different, or if there is a combined systolic and diastolic dysfunction. Now coming to one of the other debated topics, which is about the PDA. Now, the time is not there to go into details of the management of PDA. It's a hot topic and always debated. But over the last 50 years, you have seen how the management has changed. Once the PDA was diagnosed, the treatment started initially with the use of indomethacin after the Durham trial, which primarily was done for managing IVH, but it found that it also closes the duct. After that, Professor Barbara Schmidt's landmark trial, the TIP trial, published early in the century, showed that the prophylactic indomethacin, if it is used, it can reduce the IVH and reduces also the need for further treatment of the PDA, or it closes the PDA. The problem was that the PDA, when it is prophylactically treated, more than half of the ducts are or the babies are given treatment unnecessarily, as the duct would close otherwise spontaneously, even in extreme preterm babies. Then came the era where the symptomatic treatment was the focus, and various treatments have been tried, but none of the treatments have ever improved the outcomes which are of clinical interest. So far, there are no trials for the long-term outcome that has ever been done in babies with PDA with a symptomatic treatment. However, the TIP trial was had the primary outcome of the long-term follow-up at 18 months, and it failed to show any improvement in the long-term outcome. So in the last about 15-20 years, there has been an increasing use of echocardiography on the bedside to assess the PDA. And at one point of time, it was felt that we have found a magic bullet, because if we can detect the we can detect the PDA early using echocardiography, which are unlikely to close, and we close those PDA, then we are preventing unnecessary treatment of babies which were in the prophylactic group, plus we are selecting the babies who might have a dict open for a long time. This led to a change in the practice and the use of bedside echo for assessment and early treatment with ibuprofen or indomethacin and paracetamol also. So the treatment or the diagnosis of the PDA using echo requires the PDA characteristics assessment by PDA dimension and the ratio of the PDA to the left pulmonary artery, pulmonary hyperperfusion using the LAO ratio and the left ventricular output, ductal steal and systemic hypoperfusion, and now I think there is also a focus on the cardiac function and the PDA shunt, because so far it has less been integrated. Many years ago in 2007, Patrick had published the clinical and echo correlates of the PDA and classified into 4 different categories. But clinically, we all have been practicing that if the PDA is more than about 1.5 or 2 millimeters, with a pulsatile flow pattern and a volume-loaded left heart, with the findings of ductal steel, we commonly define that as a hemodynamically significant PDA. And these are the babies clinically which are ventilator dependent, refractory hypotension, or signs of heart failure. And no one is going to question about whether you would like to treat these babies. But the question is about the timing of the treatment. And so far, because it has not translated into benefit, it is still in question. And hence, the conservative approach has been finding its place in the day-to-day clinical practice. So early echo and PDA size, if you look at, when it was looked at, the duct which are moderate or large, in less than 27 weeks, one can see that they are having good predictability of 0.89, that they are continuing to stay open. Close to small PDA, the probability of requiring treatment is very, very low. So large PDAs early on diagnosed have a high probability of a later treatment. If you look at the PDA size and flow, this is seen that the large ducts have a high sensitivity that the flow pattern is going to be abnormal and they might require treatments. If there is a hyperperfusion, that is a left ventricular output of more than 300 ml per kg, this shows that the left side is volume loaded, and these are having a high sensitivity of the prediction of a symptomatic PDA later on. Ductal steel is a post-ductal steel, which means that if you are looking in the celiac artery, or if you are looking into the descending aorta, there is a reversal of the flow, and that shows that this is ductal steel, and these are the babies which are of a high risk for neck also, and hence need for drug treatment. Cardiac function and PDA shunt have come into the assessment techniques recently. And this is the data from AFIV, where various parameters on the echocardiography have been integrated to create a score. And it has been suggested by him that a score of more than 5, if done in early first 24, 48 hours, predicts the need for later treatment with a high predictive value with the area under the curve of about 0.92. Now, what have translated into practice? Now, you are aware of the 2 trials which have been recently published. One of our trials is the Baby Oscar trial, and the second is the Benedictus trial, which was by Tim Hunchfield and Willem de Boer. So this is the Bayesian unpublished data of the Bayesian meta-analysis, which was presented by Dr. Willamore very, very recently at the conference. What has been presented that the 2 large trials, which includes babies just under 1,000 in total, there is a more, as you can see all on the left side, the evidence in favor of harm, and the harm is moderate for mortality. It is moderate to severe and very strong for BPD. And for BPD or death, it is this very strong evidence to a very severe evidence that giving treatment early on in the first 72 hours, identifying with an echo, is not the right way forward, and we might be doing more harm. If you look at the trials for the strength of evidence in favor of the harm or benefit, one can see that the 2 large trials are more towards the harm, and hence there is a note of caution that until and unless there is another new way of assessing the treatment, the current echocardiographic guided treatment of PD in the first 72 hours may be more harmful than beneficial. I'll take another 5 minutes to touch upon some principles of management in specific neonatal conditions. In extreme preterm babies, they transition from the low intrauterine vascular resistance with immature myocardium and high extrauterine resistance, leading to reduced systemic blood flow. And in these cases, increasing the systemic vascular resistance, such as the use of dopamine, is not right, because it will further impede the cardiac output and it will compromise them. Now, with the bedside echocardiography, we have learned a great deal that what should be used in these babies. And now it is more and more clear that if the flow is normal and the blood pressure is normal, they don't require treatment. If the flow is low and the blood pressure is low, dobutamine and a vasopressor might be useful. But if the flow is normal and the blood pressure is slightly low, these babies could be further monitored rather jumping and giving the treatment. If the flow is low and the blood pressure is normal, it is better to treat these babies early with a dobutamine or the drug which is positive inotrope with a reduction in the systemic vascular resistance, or low dose adrenaline or epinephrine, because that is safer to use and improve their cardiac outputs. So the concept is about not to squeeze and tighten the heart, but to relax and fill the heart, because that improves the cardiac output. That improves then subsequently the blood pressure. And this is a great deal of understanding about choosing the inotropes wisely in extreme preterm babies with the help of echocardiography. In babies with hypoxic ischemic encephalopathy, again, the myocardial perfusion is reduced. There is myocardial ischemia, which leads to poor RV function, decreased pulmonary flow, and decreased left ventricular filling, reduction in the systemic and the cerebral blood flow. And hence, the approach to hemodynamic management in babies with HIE, if there's a mild transient myocardial ischemia, they are usually asymptomatic. But in the moderate to severe hypoxia ischemia, 62% of the cases do have underlying cardiac injury, and aggressive volume resuscitation should be avoided in these cases. And drugs that are used to treat the hypotension can have adverse effects like tachycardia and increase in oxygen consumption. Hence, look at the functional echocardiography, look at the cardiac function, and decide in the phases of the cooling or rewarming appropriate inotrope. And based on that, there are different phenotypes which could be associated with the LV-RV dysfunction only, or with pulmonary hypertension, or pulmonary hypertension with the RV dysfunction, or pulmonary hypertension with the LV dysfunction. So in these babies with the HIE, the treatment choice as a first line, second line, and third line, this is just a guide and varies between babies. But depending on the phenotype of the HIE with a poor cardiac function or pulmonary hypertension, the choice of drug should be decided, but consider hydrocortisone in refractory hypotension. Neonatal sepsis, warm and cold shock, and we all are aware of the warm and cold shock, and the guideline currently accepted is from pediatrics mainly. Initially, resuscitate with fluid boluses of 20 per kg. You can repeat it because if it's a shock, there could be third space losses. Inotrope use for cold shock, the initial or the first line epinephrine or dopamine. Warm shock, norepinephrine. Use hydrocortisone early if it's no response. And in the cold shock with a normal blood pressure, start with milrinone, levosimendan. If you are familiar, please use it plus volume. Cold shock with low blood pressure, norepinephrine with milrinone. Warm shock with low blood pressure, vasopressin, low dose epinephrine. Fluid inotrope, vasopressor, vasodilator, they should be used accordingly when there is no response, but early ECMO and consult if there is a refractory shock should be talked about or maybe transferred appropriately if no response is there. So I would finish with some take-home messages, and I'm sorry I've taken 5 minutes over. The understanding of transitional physiology is very important, as I showed you, because every transition is not a smooth transition, and there are 5 different types where the cardiovascular adaptation takes place. The echocardiography helps in identifying the phenotypes of pulmonary hypertension and thus selecting the appropriate drug treatment. Echo is integral to the physiology-based treatment of the poor perfusion and refractory shock. As we know, the ideal evidence-based approach is very difficult due to the paucity of the clinical data from the trials and thus guiding treatment. And hence, the physiology-based approach to management of sick babies is dependent upon the bedside use of functional echocardiography, which can guide your management. The current evidence suggests early targeted treatment of PD with ibuprofen is not beneficial, and we await the data from the paracetamol trials whether there is any benefit. Echocardiography is helpful in guiding drug treatment in specific conditions like HIE, sepsis, and LGANs. Thank you very much, and I'm happy to take any questions.
Thank you so much, Samir, for this fabulous lecture. Fantastic overview.
Thank you.
And I think it was very useful for all of us. We have almost 10 minutes for questions and comments. And so far we have received four questions here. One is from an anonymous attendee. Is it correct in pulmonary hypertension grown up after ductus closure in EUGR, open again ductus with PGE. Did you
Yeah. So
catch that?
in certain
Yeah.
IUGR, I think the question, if I rightly understand, in IUGR babies presenting with pulmonary hypertension, should the duct be opened as this is one of the complications that can occur. So I think the data again on IUGR babies, some of them they don't cope and the circulatory failure sets in, and it typically, if they present with pulmonary hypertension and the duct closes in these IUGR babies, then it can go to irreversible state very quickly. And opening the duct using prostaglandin in IUGR babies, if can be identified early using functional echocardiography, could give us more time for the cardiovascular transition to stabilize and allow the baby to improve. Otherwise, many times, if it is very severe, these babies don't have a reluctant course and they might deteriorate very soon.
Thank you. And we have several of the attendees saying thank you so much. And so I think this is a great lecture, Samir. Thank you.
Thank you.
We have a question here from Carmen. Do you use INO in extreme preterm, like 23 weeks?
Excellent
Yeah.
question.
Yeah.
So as you know, the current trials, they have not shown the benefit, but in extreme preterm babies where the pulmonary hypertension of the pre-capillary type is documented using the functional echocardiography, the INO is found to be helpful, and it is on a case-by-case basis rather as a routine recommendation. And hence, on a case-by-case basis in extreme preterm babies, if there is a pre-capillary pulmonary hypertension, low dose INO to start with is something that one could try. So again, it varies from center to center. Some centers might start with 20 ppm, but it has not been based on the evidence, but it is based on the physiology and the local practices. But there is a place of INO in extreme preterm babies with a documented pre-capillary pulmonary hypertension.
Thank you. I think that was very valuable, interesting question, because I think we have been discussing for years whether or not we should give INO to these smallest babies. Where can we learn the echo in newborn? Are there any courses organized somewhere? I'm sure you know that.
Yeah, I think I must say that we have now at the European Society of Pediatric Research Circulation section established a neonatologist perform echocardiography curriculum, and that curriculum is now being piloted in 3 sites, including ours, and has found to be useful, which is going to be rolled out, and more centers will be utilizing the NPE curriculum, which is standardized and well reviewed, to be integrated in the centers around the world, which could be used for training purposes. At the moment, the demand is far more than it can be coped with, and the courses do happen with the large conferences, including our center. We do it in UK. There are courses in Canada, North America, Australia, in Europe. So again, it is very center specific driven, but in due course, I think it is going to be more and more available for people to take it up. And there are 2 types I would just differentiate here. One is the full, what we call targeted neonatal echocardiography, or neonatologist perform echocardiography, as we say in Europe, which is a full year training and expertise in doing the functional echoes. Otherwise, the POCUS, which is coming point of care ultrasound, also have a cardiac component, which is a limited echo, which could be done and looking at a specific question to see a specific answer by putting the probe on the chest, which can be learned very quickly. And POCUS is getting integrated in many programs because it is found to be useful in emergency departments also. So depending on what your choice is, you could do a POCUS or you can do a full functional echo course.
Thank you. And then there's a question about the Bosentan. My question is, what do you think about the use of bosentan, and for which type of pulmonary hypertension would it be most indicated?
This is again a great question. The bosentan is one of the pulmonary vasodilators which works through the endothelin pathway. And hence, if you have used drug which is using the prostacyclin pathway or the cyclic AMP pathway, then if you require to add a bosentan, typically if the centers are having the facilities of the pediatric cardiologist, I would suggest a consult with a pediatric cardiologist for a full scan, because these are the babies who would require the long-term follow-up, including the pulmonologist and the cardiologist input required in these cases. So if bosentan has to be used, it can be used in refractory pulmonary hypertension where the sildenafil, prostacyclin, and they are found to be only partially effective or not effective. One can add bosentan. There is also a recommendation from the European guideline for the management of pulmonary hypertension that before the bosentan is added, a cardiac cath might be also desirable, but it is not laid down in practice. The use of bosentan is also seen when the pulmonary hypertension is refractory, and many cases of the BPD-associated pulmonary hypertension, people try to use bosentan as another the therapies in addition to sildenafil. The trials are not, there with a conclusive evidence about the usefulness of it in the babies, but these are the scenarios where we use the bosentan in cases of pulmonary hypertension.
Thank you. And then we have several of the participants thanking you for excellent presentation. So much information to digest and so forth. So this has been a great success, Samir. And then we have from Khalid Lagmiri, cardiomyopathy, cardiomyopathic hypertrophy in term baby and HTAP ?
So again, if I rightly understand the question, the cardiomyopathy, depending upon the type, are we talking about hypertrophic cardiomyopathy or dilated cardiomyopathy? If it's a dilated cardiomyopathy, there is usually a pulmonary vascular congestion. And if these babies, they are primarily presenting with a shock, and if there is a long-standing and associated pulmonary venous hypertension, then the treatment is primarily by the pediatric cardiologist, and that should be referred to them, because one need to find out the underlying genetic diagnosis and the treatment, and whether these patients require a VET device or transplant, because this is a long-term management required for these cases. But if it's a hypertrophic cardiomyopathy, then the treatment is again different, because this is the reduction in the output, and there the systemic vasodilators might play a role, such as captopril. But again, these should not be managed, in my view, by the neonatologist primarily, and a consult with the pediatric cardiologist is desirable.
Thank you. Then it's a question from Adam Silinek. In the absence of INO, do you recommend starting with sildenafil in treatment of PPHN in case there is a good heart function? Milrinone when there is a poor heart function?
Yeah, I think it is true, as you have mentioned, that INO might not be available in many parts of the world. And if it is not available, and if you have access to sildenafil, it has been used successfully in management of pulmonary hypertension. And as you rightly mentioned, if the sildenafil is used, one has to titrate the dose. And if you have a functional echo available on the bedside, it is desirable to do that. Start the milrinone to improve the cardiac function, and titrate it and wean it alongside the use of sildenafil. Sildenafil, if you are starting, the treatment is usually required for a longer time, because it can be used, and the babies can then be followed about growing out of it or reduction in the dose gradually, because there is a very good dose-response relationship, and sildenafil can indeed be used in place of INO, and as you are rightly mentioned, milrinone to be used with the poor cardiac function. But one needs to be careful. If you are using milrinone and sildenafil together, both of them, they reduce the systemic vascular resistance. The babies can go into reduction in the blood pressure, and you need to be cautious about monitoring the blood pressure. And if in doubt, a low dose epinephrine or vasopressin. I would not suggest vasopressin because it is difficult to titrate, but low dose epinephrine could be used in these cases to offset the dilatory effect of both the drugs on systemic vascular resistance.
And there's a question related to that, because Milrinone is not always available in all countries. So the question is, can sildenafil, oral sildenafil, be used instead of IV Milrinone in all circumstances or only in certain circumstances?
Yeah, I would beg to differ on there because the effects are obviously different. So the phosphodiesterase 3 and phosphodiesterase 5 inhibitors are the two drugs, and both of them will cause the pulmonary vasodilatation indeed. However, milrinone is effective for cardiac dysfunction because it's a lucitrope and improves the contractility. If the baby has poor cardiac function, then sildenafil alone is not going to help. And you would require an inotrope. And if you do not have a milrinone, then epinephrine needs to be added. Dobutamine can be added. But then these drugs will not have a pulmonary vasodilatory effect as what the milrinone has. So it is more about titrating the drugs which are locally available and opting for the best response.
Thank you. We are now running out of time, but if you don't mind, maybe we can take a few more questions.
Sure.
And for those of you who do not get your questions answered, I think Professor Gupta will give out answers on the website later on.
Sure.
So there's a question here. Do we keep the ductus open when the pulmonary pressure is suprasystemic? And do we shunt through the ductus from right to left or bidirectional?
Okay, so if the pulmonary hypertension typically, the pulmonary pressures are either equal to or more than the systemic pressures. Now, if they are equal to systemic pressures, you will get a bidirectional shunting across the duct. So if the duct is having a bidirectional shunting, and if it is more than 30% right to left, that suggests that the pulmonary hypertension is significant. But if it is less than 30% right to left, then these are the babies where the pulmonary hypertension is not severe enough, and in these babies, the duct can still be closed. So if you are having a right to left flow across the ductus more than 30% in the first few days of life, definitely, then these are the babies with pulmonary hypertension, and one should manage on the lines of pulmonary hypertension as what we have discussed. But if the duct is left to right or less than 30% right to left, one can go for the closure of the duct if everything else is normal. The second part of it is that if the duct is large and the flow is mainly right to left, and there is pulmonary hypertension, then as I mentioned in the talk, then one should not attempt to close the duct unless you have reduced the pulmonary bed pressures and established that the right ventricular function is normal. Because in absence of a normal right ventricular function, if you close a large duct in presence of pulmonary hypertension, these babies can succumb suddenly and they can even die. So one has to be very careful in large ducts with a pulmonary hypertension and a right to left flow to assess the RV function, pulmonary vascular resistance, and essentially see the reversibility of it, and then refer to the pediatric cardiology center for the further management in terms of assessment of it using the catheterization and then guiding the treatment based on the cath studies.
Okay, and then it's a question from Svetlana. She's thanking you for your lecture. And she asks, please describe the place of levosimendan in treatment of neonatal shock. I've seen it's been recommended only on the slide about septic shock.
Correct. So again, the experience of using levosimendan is very thin, and so far, centers that have the experience of using it, they primarily use in cases where there is a septic shock, because it is found to be helpful and with a good response. Our use of levosimendan in our center is again very, very thin and very rarely used. But the guidelines from the pediatrics which have been adopted in the neonates for management of shock describe the use of levosimendan in this group of babies. So I'm sorry I cannot comment more than that on use of levosimendan, but it is a drug that could be used based on its the effects.
And then there's a question about extremis with severe BPD and PDA. Should we attempt to pharmacologically treat established pulmonary hypertension on such babies?
Excellent question. Yeah, I think it is increasingly recognized that the chronic pulmonary hypertension, which is which is not infrequently seen in babies who are born extremely premature, is more and more recognized. And on our center and many centers who do the functional echoes routinely, by the time babies get to about 32 weeks, and they're still dependent on any oxygen or respiratory support, we start to look for pulmonary hypertension. But definitely at 36 weeks, the echo is warranted in babies, particularly those who are on respiratory support or oxygen, to make sure that there is no pulmonary hypertension underlying. If there is high pulmonary pressures associated with BPD who are dependent on any respiratory support, these are the babies where you would want to lower the pulmonary vascular resistance by giving drugs like sildenafil, as this is progressive disease, and in presence of BPD, the chronic pulmonary hypertension is well described now and managed with the use of sildenafil after doing an echo between starting at 32 weeks and definitely from 36 weeks.
And then Monica is asking you if sildenafil can be used enterally, or do you recommend only venous infusion?
The enteral sildenafil can be used. So on our center, if the babies are ventilated and ill by mouth and sick, we start IV sildenafil. But we try then subsequently, once they get better, particularly cases like diaphragmatic hernia, we do go from IV to enteral sildenafil, because then the babies are continued on sildenafil till they grow out of it, and this can take between 3 to 6 months.
And then maybe a final question is from Milena. She thank you for the lecture, and she asked if you would use INO in babies with pulmonary hypertension and left ventricular dysfunction.
That's what I tried to describe, that if there's a left ventricular dysfunction, one needs to look at, if with a functional echo, that is the duct right to left, and the interatrial flow, is it left to right? If that is the case with a left ventricular dysfunction, that the interatrial flow is left to right and across the duct is right to left, this is the functional echocardiography diagnosis of a pulmonary venous hypertension. In these situations, INO should not be used. But if you are not able to do the functional echo, and you find that the baby has left ventricular dysfunction and is hypoxic, in many situations, it is better to improve the left ventricular function before you commence the nitric oxide.
Okay, we have some more questions left. I think our time is out, and Professor Gupta has promised